Hello, hello, students. Welcome to Concepts of Care for Patients with Arthritis and Total Joint Arthroplasty, Part 2. Okay, so we're going to talk about the surgical management. Um, Drug therapy no longer provides pain control when mobility becomes so restricted that patients cannot participate in activities and when the desired quality of life cannot be maintained. This is when surgery comes into place, right? The most common surgical procedures for osteoarthritis is total joint arthroplasty, surgical creation of a functional synovial joint using implants, also known as total joint replacement. So this is the big umbrella. Under the total joint arthroplasty, you're going to have the hip replacement, knee replacement, shoulder replacement. Okay, the hip and knee are most often replaced, but shoulder and ankle arthroplasties are becoming increasingly common as a result of advances in technology. So, for example, let's watch the video of the shoulder replacement. Okay, okay, let's watch this video.
A total shoulder replacement is a surgical procedure to replace your shoulder joint. Your main shoulder joint is made up of two bones, the top or head of your upper arm bone, called the humerus, and part of your shoulder blade, or scapula, called the glenoid. It's called a ball and socket joint because the ball-like head of your humerus fits into the cup-like socket of the glenoid. A total shoulder replacement is often done to ease pain from shoulder conditions, such as arthritis or severe bone fractures. Your joint will be replaced with an artificial joint called a prosthesis. It has two parts that look like the bones of the shoulder joint, a ball with a stem and a socket. A total shoulder replacement will begin with an incision over your shoulder joint. After reaching your shoulder joint, your surgeon will remove the damaged head of your humerus. Then a hole will be made inside your humerus. Next, the socket of the glenoid will be reshaped. Then holes will be drilled for the socket part of the prosthesis. Your surgeon will place the socket part of the prosthesis into this area, and the ball part of the prosthesis will be placed into the hole in the humerus. Finally, your surgeon will slide the ball of the prosthesis into the new socket. At the end of the procedure, the incision will be closed with staples or stitches. After the procedure, you will need to wear a sling on your arm for a few weeks while your shoulder heals. For more information about a total shoulder replacement, talk to your healthcare provider.
Thank you so much. So, believe it or not, in these last 2 months, I met two patients that were having shoulder replacement after playing these virtual reality games. Those that are it's like a camera in a shape of frames or glasses, right? And they were playing this game, and somehow they thought they were seeing an obstacle, a stone, an animal, so they start fighting. They fall. Anyway, so they ended up with shoulder replacement. So it's very common that people are getting these types of surgery. You need to double check. Also, young adults with a scooter, when they try to avoid falling in the cement, the first thing they are going to put is either the wrist or the elbow, but they are going to fall on top of the shoulder. So that's another common incident. Okay, total joint arthroplasty is a procedure used more often to manage the pain of osteoarthritis and improve mobility, although other conditions using cartilage and bone destruction may require the surgery. Rheumatoid arthritis, for example, right? Osteonecrosis is bone death secondary to lack of or disruption in blood supply to the affected bone, usually from trauma or chronic steroid therapy. That's why steroid therapy is something you need to evaluate, especially if you're living by yourself and you don't have anybody to take care of you, and if somebody is trying to get long-term steroid therapy, you know that osteoporosis is a risk, right? So the affected bone site is most commonly the femoral or humeral head, distal femur, or proximal tibia. The contraindications for the total joint arthroplasty are active infection anywhere in the body and rapidly progressive inflammation. An active infection elsewhere in the body or form the joint being replaced, uncontrolled diabetes, hypertension, put the patient at risk for major postoperative complications. So every time for any type of surgery, I think we should see it in this way instead of repeating, right? Every time after surgery, we need to check for infection, and we have to be aware that uncontrolled diabetic patients are going to have a long healing process. The same with hypertension, right? Patients who smoke should plan to enroll in a smoking cessation program and stop smoking prior to surgery to help prevent cardiovascular complications of surgery. We know the relationship between osteoporosis, osteoarthritis, and smoking, right? So this is a safety alert. So let's talk about the total hip arthroplasty, and let's watch this video. In the previous one, in the shoulder, we were talking about the humeral, right? The humerus bone. I call them my human resources bones, the ones in the upper extremity. So you have the humerus, you have the ulnar, and you have the radial. That's why I call it the human, HU, humeral, ulnar, R, radial. So my human resources bone. And then at the bottom, the lower extremities, I call the full-time bones, right? So I have the femoral, then I have the tibia, and I have the fibula. Okay, so I remember those bones like that. Okay, so let's watch this video, please. Oh, 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 oh. Okay, let's watch these videos. I'm getting worse with this.
This is a surgery to fix a damaged or diseased hip. It replaces your hip with implants that restore function to your joint. Instead of the single large incision used in a traditional hip replacement surgery, this method uses 2 small incisions. This helps speed your recovery. To begin, you are put to sleep. The surgeon makes 2 incisions to reach your hip joint. Then, the large leg bone or femur is separated from the socket. The head of the femur is removed. To fix the socket, the surgeon removes damaged tissue and bone from the pelvis. Then, a shell is secured into the bone. A liner is locked into the shell. The liner creates a smooth surface that will allow the joint to move freely. The surgeon now focuses on the femur implant. The end of the femur is hollowed out. A long, narrow implant called a stem is placed into the femur. The top of the stem is fitted with a ball. The ball is placed into the socket and the joint is tested. Finally, your incisions are closed and bandaged. After the surgery, you are watched in a recovery room as you wake up. Your surgeon will tell you when you can go home. Follow your surgeon's advice for a safe recovery.
So kind of similar, the hip and the shoulder replacement, both are treated, and the surgery is concentrated on the socket, right, to replace that area, because these joints are fully movable. They are doing rotation, abduction, adduction, right? Flexion, extension. So these are very similar surgeries. The procedure is performed most often in those older than 60 years. We are talking about the hip. The special needs and normal psychological changes of older adults often complicate the perioperative period and may result in additional postoperative complications. So it's very crucial to identify the comorbidities and any physical complications before the surgery in order to prevent and to planify how the post-operative complications are going to present, if any, or what type of nursing care the patient needs. Preoperative care, identifying a joint coach, so it's a family care partner can help the patient through the perioperative period and assist with discharge needs. The surgeon explained the procedure and post-operative expectation, including possible complications during the office visit, but the patient education may have occurred weeks or months before the scheduled elective surgery. That's why it's important to keep repeating, especially in these older older patients. We need to repeat the explanation. That's why the specialist is asking for a joint coach so they can train the patients. Written material or other media provided in the language appropriate for the patient's reading level and culture are essential. So that's another thing that they need to think in advance. Preoperative rehabilitation or prehab is essential to prevent functional decline after surgery and provide a quicker functional recovery. It is called the prehab, right? As part of the prehab, the patient and joint coach learn post-operative exercises. This is extremely important. So transfer and positioning techniques and ambulation with a walker or crutches depending on the patient's age and stability. So they are going to teach them how to manage the joint post-surgery, how to control certain positions, transferring, walking. In addition, patients preparing for elective orthopedic surgery may be screened for their risk of post-operative delirium to anticipate the need for safety sitters to prevent patient falls. This is safety, safety, safety. They are going to monitor and evaluate the patient to see if he will have delirium post-surgery. Enhance recovery after surgery. I want you to pay attention, please, on this. Enhance recovery after surgery ERAS program, also called Fast Track, Accelerated Track, or Rapid Recovery programs, are common in total joint replacement centers to improve patient outcomes such as shortened hospital length of stay, improve patient experiences, and enhance functional outcomes. So let's remember that is enhance recovery after surgery programs. Pretty much they are set up in all these rehab units or total joint replacement centers. Enhance recovery after surgery, from now on, is going to be called ERAS, okay? In addition to usual preoperative laboratory tests and x-rays, the surgeon may ask the patient with rheumatoid arthritis to undergo a cervical spine x-ray if having general anesthesia. Those with rheumatoid arthritis have often cervical spine disease that can lead to subluxation. That means partial joint dislocation during intubation. A CT scan and MRI may be done to assess the operative joint and surrounding soft tissues, especially if the patient is undergoing a robotic assisted total hip replacement. Extremely important, 86% of patients with rheumatoid arthritis have a complication with cervical spine, okay? So even though the patient with rheumatoid arthritis, and let's clarify this, the patient with rheumatoid arthritis can go for a total hip replacement surgery in the moment they are going to put anesthesia or something goes wrong and they want to intubate the patient, they need to know if the patient is having any cervical spine complication, right? Because during the intubation, more complications can develop, a subluxation, okay? So we are talking about hip replacement, but if the patient on top of that is having rheumatoid arthritis, we need to check for cervical spine complication. Okay, and this is good to know. Okay, ask patient to check with their surgeon about which drug they can take in the morning of the surgery. Of course, we always need to do that with any surgery. If they are taking hypertensive, if they are taking anti-diabetic medications, thyroid medications, etc., 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 NSAIDs, anticoagulants, antiplatelets, especially this last one, the NSAIDs, anticoagulants, antiplatelets are discontinued 5 to 10 days before surgery to prevent surgical bleeding. So this paragraph here that I'm going to highlight in green is a standard of care, okay, for all the surgeries, not only in this particular case scenario, right? Before the surgery, you check all the medications that the patient is allowed to take in the morning of the surgery, and also you're going to double check medications that can cause a bleeding, and so you have to inform the patient about preventing discontinue the use of these medications 5 to 10 days before the surgery. Preoperative procedure, similar to other orthopedic surgeries, the patient receives antibiotic, which this could be a cephalosporin, such as cefazolin or cefuroxime, within an hour before the initial surgical incision per surgical care improvement. This is another protocol, okay? Surgical Care Improvement Project, core measures to prevent infections, okay? So this is the protocol as per this standard of care to provide antibiotics before the procedure. If the patient has a beta-lactam allergy, vancomycin or clindamycin is administered 2 hours before the initial incision. So then we have the box: patient and family education, preoperative care, and education for patients having a total hip arthroplasty or hip replacement. Most important is to assess nutrition, to see the need for preoperative assessment for clinical malnutrition, which is associated with prolonged postoperative rehabilitation and surgical complications. You have to understand the importance of nutrition to this point, right? It's not only during the prevention when the patient is in risk for getting osteoarthritis or osteoporosis, but look, even before the surgery, they want to know how the nutritional status is in order to give you a prognosis of how the recovery is going to be. So vitamin C, A, E are important in wound healing. Proper nutrition can help your body heal faster and fight infection. Enough protein, fluids, zinc, which is excellent for wound healing. B complex, cranberry. B complex because certainly some nerves are going to be, they are not going to be managed, but in some way they are going to be, what is the word? Compromised, right? Cranberry, collagen, biotin, and vitamin D. Pain assessment and management. Assess for use of opioids for persistent pain before surgery. So the patient who is used to get these opioids, they need to double check if he's going to be responsive to certain analgesics during the surgery and after the procedure, right? Okay, so then we are going also to check for venous thromboembolism, VTE prevention, teach the need for anticoagulant drug therapy, which should start within 24 hours after the surgery and continue for at least 14 days after the surgery. For patients taking anticoagulants or antiplatelet drugs before the surgery, plan for interruption of these drugs 5 to 10 days before the procedure. We need to teach the need for frequent mobilization after the surgery. Usually it's going to be a couple of hours, 8 hours to 10 hours after the completion of the procedure, to prevent constipation as well, and teach the need for compression stockings and sequential compression devices during the hospital stays. Those are really helpful. Infection prevention, we know that probably they are going to receive antibiotics before surgery and possible up to 24 hours after surgery, depending on how the surgeon is going to see the tissue in the moment of the operation. So the most important, we need to be aware, alert, is Staphylococcus aureus 2 to 4 weeks before the surgeon. Especially we need to screen for NERS, the nose colonization of this bacteria. Teach the need to use nasal mupirocin ointment twice a day for 1 week or longer. Teach the need to bath with chlorhexidine, gluconate solution or wipes for at least the night before and the morning of surgery. This part is here very important. I don't know why they put it at the bottom. Teach the patient to sleep on clean linens and not to use lotion or powders after the chlorhexidine gluconate bath. Remind the patient to avoid sleeping with pets in the bed. So we know how patients are used to live with pets, so many of them, they are sleeping with the pets in the bed. So for me, this is one of the most important teaching. Preventing hypothermia is another important goal during total hip replacement, because it is associated with increased blood loss, increased risk for infection, and increased risk for a cardiac event. Patients with a low body mass index are the high risk for hypothermia. It is important to keep the patient warm even after surgery. Remember, nurses, that after anesthesia, the patient may experience a sensation of coldness. Whenever the effect of anesthesia is gone, usually patient feel the coldness. So you need to keep the patient warm. Some patients are candidates for minimally invasive surgery, cannot be used for patients who are obese or those with osteoporosis. It is done only for primary hip replacement, not for revision surgeries, and that's important also to know. Hip resurfacing is an alternative to total hip replacement surgery. This procedure is most often performed to younger patients or for those with early stage cartilage loss of the weight-bearing surface of the femoral head. Instead of completely removing the femoral head and inserting the stem into the femoral canal, the surgeon removed the cartilage from the surface of an artificial cap, and an artificial cap is placed over the existing natural femoral head. So that's just the basics of how the surgery is done. We saw a video, and we really need to focus on nursing care, but we need to have an idea, right, of how the procedure is going to be. 3 surgical approaches are commonly used to perform total hip replacement. Nursing care and patient education differ slightly depending on which approach is used. Be sure to confirm the surgeon's surgical method for each patient. As I said, it's important to know what is the approach of the surgery so we can planify nursing care. For the anterior approach, that means the approach is going to be in the front, right? The hip joint can be exposed without detaching surrounding muscles. Therefore, this approach has the least likely chance of postoperative hip dislocations, and this is extremely important and may have the quickest postoperative recovery. So when we have the anterior approach in hip replacement, the chance of postoperative hip dislocation is going to be less, right? The chance of danger of dislocation is going to be less likely. So we have the instruments here that we saw in the video. Both of the other surgical methods, direct lateral and posterolateral. Okay, direct lateral means lateral on the side, and posterolateral is in the back. Okay, lateral, so it's in the back towards the side. Require detaching and or cutting into large skeletal muscles, which can cause severe postoperative pain and high risk for hip dislocation. The posterolateral approach has the higher risk for dislocation and is therefore seldom used. So this is very important to know, at least for you guys if you're going to work in a rehab center or a total joint replacement center, okay? Or a rehab unit. Post-operative care, the typical hospital stay for the patient having the total hip replacement is 3 days unless the patient participates in an ERAS program, which we know what it is. It's enhanced recovery after surgery programs, right? So one of the most common complications after a total hip replacement is hip dislocation. We know that. So for hip dislocation, basically what we are going to do is to put the patient in the abduction position, right? Abduction position, right? So we're going to use, there's special pillows in the shape of a triangle that is going to be placed between the legs. So the patient is going to be in abduction position. Other complications include venous thromboembolism, infection, and complication of decreased mobility. We know this with any surgery, possibility of infection, thromboembolism, because after surgery, most of the patients are going to be in bed rest, right? Preventing hip dislocation, place the patient in a supine position with the head slightly elevated. 1 or 2 regular bed pillows are used in most cases to remind patients to keep their legs abducted. If an abduction device with the straps is used to prevent dislocation, be sure to loosen the straps every 2 hours and check the patient's skin for irritation and breakdown. Yes, the thing is that these pillows that has the triangle face shape, when they are placed in between the legs, some of the nurses, they use these types of straps to secure that and to avoid the patient to move. But you need to check for skin irritation or breakdown. Turning the patient. Okay, here comes the very, very, very important part. Let me get some water first. Okay. Turning the patient to the operative side provides splinting of the operative hip, but may be too painful for some patients. If the patient is turned to the non-operative side, let's say the patient got a hip replacement of the right side, right? So you are turning the patient to the non-operative, meaning the left. The operative leg needs to be fully supported with pillows to prevent slipping of the leg into an abducted position that can lead to dislocation. So this turning, okay, I highly recommend. I work as a PCA in a rehab unit, and this turning was made by 2 experienced nurses. And you need to get authorization for this type of movements, not only by the surgeon, but also the nurse manager. okay? Because sometimes it's better to keep the patient in the sitting, in the supine position, and then if you are going to rotate, to turn the patient, you need two nurses to do this in order to have the patient, in order to avoid dislocation, okay? So make sure you don't want to have a problem, the patient can have a dislocation, and then you're going to be receiving a warning alert, okay? 3 warnings alert, you're out of the hospital. Okay, so patient-centered care, older adult health. Special postoperative care of the older adult with a total hip replacement, arthroplasty, okay. When caring for older adults, be sure to incorporate this postoperative evidence-based nursing action. For patients who had a posterolateral or direct lateral surgical approach, which we know are those that are going to expose certain muscles, right? Use an abduction pillow or splint rather than bed pillow. The abduction pillow is the triangle pillow that I'm telling you, to keep their legs apart and prevent adduction, especially if the patient is very restless or has an altered mental state. That's we talked about delirium before, right? So all this assessment needs to be done. Mental status, if the patient is going to handle certain types of analgesics, opioids, etc., etc. If the patient is having, let's say, is anxious because today his daughter was supposed to come and she is not showing up until 10 p.m. So then the patient start behaving weird, right? Hip adduction can cause the surgical hip to move partially or completely dislocated. So safety, safety, safety alert. Call another nurse and do this turning with another experienced nurse. Yes, keep the patient's heels off the bed to prevent pressure ulcers. Do not rely on fever as a sign of infection. Older patients often have infection without fever, and this is the rule for all types of diseases, procedures, surgery, and hospital stays. Okay? Be alert to decreasing mental status and or elevated white blood cell count as indications of infection. This is so you don't rely on the fever as a sign of infection. However, you are going to rely and double check your WBCs if they are elevated, right, as an indicator of infection. And this is NCLEX alert, okay? When you are assisting the patients out of bed, move slowly to prevent orthostatic hypotension. This is common knowledge. We need to know all these precautions post-surgery, right? And even at the moment of discharge, we need to evaluate for orthostatic postural hypotension. Allow the patient to sit on the side of the bed for a brief period of time before standing, and you need to help the patient at the beginning of ambulation. Encourage the patient to deep breathe and cough and to use the incentive spirometer every 2 hours to prevent atelectasis and pneumonia. That's another common protocol, right? Evaluate for infection, DVT for venous thromboembolism, check the mental status, check for infection, use the incentive spirometer to prevent atelectasis and pneumonia, make the patient ambulate 6 to 8 hours after the procedure. Those are common protocols that are valid for every surgery, okay? In the surgical side, get the patient out of bed to recliner chair to prevent complications, okay? Anticipate the patient's needs for pain medication, especially if unable to verbalize the need of pain for pain control. For patients on a multimodal pain control, assess the need to medicate for breakthrough pain. Expect a temporary change in mental state immediately after surgery, yes, as a result of the anesthetic and unfamiliar sensory stimuli. So, if you are going to work in med surg after surgery, or or PACU, right? After surgery, there are some patients that they start crying. That is like a side effect when the anesthesia is leaving the body, right? So you can get cold, and patient can change their emotions. Really, they can start crying not because of the pain, but because they feel vulnerable. They feel that they should not be going through this procedure or something like that, or maybe they feel lonely, right? There's no family members for them to come to visit them. If the surgical hip becomes dislocated, the surgeon may be able to manipulate and relocate it after the patient receives moderate sedation. And this is done by the surgeon. You nurses don't touch the hip that is dislocated, okay? If the hip does not reduce into position, the patient may have surgical reduction in the operating room. Okay, very good. So, nursing safety priority, action alert. As with other musculoskeletal surgery, monitor neurovascular assessment frequently for a possible compromise in circulation to the affected distal extremity following total hip replacement. Check and document color, temperature, distant pulses, capillary refill movement, and sensation. We know that is the standard of care for after a procedure. Preventing postoperative complication, the most potentially life-threatening and commonly occurring complication is VTE, venous thromboembolism, which includes, okay, this is excellent because I want you to clarify. Many nurses, they get confused between deep vein thrombosis, pulmonary embolism, or what is the most potential life-threatening after surgery. So venous thromboembolism is kind of the umbrella. And from that umbrella, you have deep vein thrombosis and pulmonary embolism. Okay. Older patients are especially at increased risk for VTE because of age and decreased circulations before surgery. So obese patients who currently smoke, and those with a history of venous thromboembolism are also a high risk for thrombo. Okay. Pharmacology, ambulation, and compression pack. We need to practice those evidence-based post-operative intervention like anticoagulants such as subcutaneous low molecular weight bearing are effective drugs in preventing VTE in patients with hip replacement. Early ambulation is suggested. Also, be sure that the patient ambulates at least 3 times a day. Teach the patient about leg exercises, which should begin in the immediate postoperative period and continue throughout the rehabilitation period. These exercises include plantar flexion, dorsiflexion, heel pumping, circumduction, circles of the feet, gluteal and quadriceps muscle setting, and straight leg exercises. I'm gonna show you what these exercises are, so you have to be familiarized. But basically, when the patient is having a hip replacement, usually it's done on a rehab unit, and there is physical therapists around, so they are going to teach the patient these exercises. So this is a good way for you to be informed and to know the exercises. Okay. Oh, okay. No voice. Hold for 5 seconds. Tight the muscle. So this is the incorrect way. You don't have to tighten the gluteal muscle. Perfect. That's the muscle. This is the right weight, and the other one, the gluteal, is the incorrect way. And the other type of exercise is the straight leg rises. Let me put this video.
Next exercise is a straight leg raise. We're going to start with both legs straight, lying on your back on your bed. You're going to keep your legs straight as you lift one up at a time and then back down. Feeling the top of your leg work, lifting it up and back down. And we're going to aim for 8 to 10 on each side.
Excellent. Okay, intermittent pneumatic compression devices, also called bilateral sequential compression devices, are important in preventing VTE by increasing venous blood flow during periods of inactivity. So monitor the surgical incision and vital signs carefully every 4 hours for the first 24 hours and every 8 to 12 hours thereafter, following facility and surgeon protocols. Observe signs of infection as again, such as elevated temperature, increased redness, hyperpigmentation around the incision, and excessive or foul smelling drainage from the incision. These signs and symptoms may be seen as early 2 to 3 days after surgery. So keep an eye on that. Managing postoperative pain usually is going to be the protocol of the anesthesiology. However, in view of the opioid crisis and multimodal pain management approaches, the best practice for patients having a major joint arthroplasty, immediate pain control may be achieved by short-term patient control anesthesia pump or IV push. Typically, IV push is going to be morphine or hydromorphine. Demonstrated that oral patient control analgesia with oxycodone is effective in managing pain for patients having total joint arthroplasty. Non-opioid drugs are used as part of the multimodal analgesia approach because they act at different pain receptor sites. Examples are continuous peripheral nerve block like bupivacaine, your NSAIDs, ketorolac, celecoxib, receptor antagonists like ketamine, and gabapentoins, gabapentin. So these medications work in different areas, right? You know, your NSAIDs, ketorolac, and celecoxib. This is the celecoxib is working on your COX-2. Ketorolac, be careful and always assess if the patient has history of bleeding. So ketorolac shouldn't be given if the patient has history of bleeding. Your gabapentoids are basically for nerve pain, right? Related to the surgeries, your gabapentin. So another one that I want to mention, oxycodone. These medications is we need to be careful because the patient can become dependent from this medication, okay? And at some point, the medication is not going to work, so they will going to ask you for a higher dose. So all these things we need to take into consideration. Non-pharmacologic methods for acute or chronic pain control, cryotherapy, and music therapy. I've seen these works very well. We know that cryotherapy is cold compressors, and music therapy works very well in parallel with your PCA pump, right? Promoting postoperative mobility and activity depending on the time of the day that the surgery is performed. The patient gets out of bed with assistance the night of surgery to prevent problems related to decreased mobility like venous thromboembolism, pneumonia, especially in older adults. So be sure to assist the patient first time getting out of bed to prevent falls and observe for dizziness. And I'm going to show you a video with the right technique, your body mechanics, how to transfer a patient from the bed to the chair the first time post-surgery.
Okay, stand, pivot, bed to wheelchair. Here's how the wheelchair looks. Okay. You're going to fix your feet, heels towards the wheelchair, leg in between theirs. Okay. Thank you.
So she's using a belt. She's transferring. Exactly.
And wheelchair at 30 degrees. Yes. Okay, edge of bed, scooted. Okay, stand.
So basically she was using the belt, and she was using proper body mechanics. She was flexing the knees, and then she was putting the patient knee in between the CNA's knees. Okay, that's proper. If you have a certification, a CNA certification, these are one of the techniques to transfer patient from the bed to the chair. In collaboration with the physical therapy, teach the patient how to follow weight-bearing restrictions. Most patients use a walker, but younger adults may use crutches. NCLEX question. The nurse plans care for a patient who underwent an anterior total hip arthroplasty, an anterior total hip replacement this morning. What is the priority action that the nurse would include? Administer continued peripheral nerve block per agency protocol. Keep the operative leg adducted for the first 2 days. No way. Assist the client to get out of bed and ambulate this evening. Yes. Monitor for dislocation of the operative hip while in bed. So the first thing we are going to do is to assist the patient out of bed and ambulate this evening. Okay, so let's talk now about the hospital readmission after total hip arthroplastic. The most common complication after surgery that cause readmission to the hospital include thromboembolic problems such as DVT and stroke, surgical site infections, and systemic infection including pneumonia and sepsis. Men of advanced age and those with comorbidities such as heart failure and diabetes are at the highest risk for hospital readmission after total hip replacement, and that's good to know. NCLEX alert. Patient and family education, care of patient with total hip arthroplasty after hospital discharge. Hip precautions: do not sit or stand for prolonged periods. Do not cross your legs. Again, we need to keep the patient in the abduction position. For posterolateral or direct lateral surgical approach patient, do not bend your hips more than 90 degrees. For anterior surgical approach patient, do not hyperextend your operative leg behind you, right behind you. Do not twist your body when standing. Do not put weight on your affected leg. Call 911 if you experience any signs and symptoms of hip dislocation. Resume sexual intercourse as usual on the advice of your surgeon. Pain management: report increased hip or anterior thigh pain. Take oral analgesics as prescribed. Do not overexert yourself. Use ice or cryotherapy as needed with operative hip to decrease or prevent swelling and minimize pain. Incisional care: most important is to double check for redness, hyperpigmentation, heat, or drainage. If any of these are present, call the surgeon immediately. Do not bathe the incision or apply anything directly to the incision unless instructed to do so. Shower according to the surgeon's instruction. Other care: feel free to read this area. And let's stop here, and when we come back, we are going to talk about total knee arthroplasty. Stay tuned.